Hello and welcome you all. I am Dr. Dipanjan Chatterjee, and in the next 15 to 20 minutes, we will be discussing about the basics of ECMO and the indications and contraindications. I have no conflict of interest and no disclosures to be made. So these are the basic structures around which I'll base my talk on. So why do we need to know about ECMO? Why do we need to study ECMO? Why do we need to make ECMO more popular? You can see that ELSO, which is the parent organization which keeps a registry, shows that every year the number of centers who are performing ECMO is increasing, and the ECMO is being performed on more and more patients. Even the outcome of ECMO is getting better with the passing years, mainly because we have a better knowledge about the pathophysiology, and also the machineries are also improving. Before we discuss ECMO, let's go back to the history. Before the 1952 polio epidemic, even the ventilators were not common in the ICUs. It was only during this polio epidemic that ventilators were used to ventilate the patients, and these iron lungs, which were negative pressure ventilators, saved a lot of lives. Then came the positive pressure ventilation. ECMO, as we see today, the first cases of use of ECMO came up in the 1970s. Actually, ECMO can be considered to be a continuation of the cardiopulmonary bypass that we see in the cardiothoracic OTs, but now it has been modified quite a bit. In spite of the initial success stories, ECMO utility was not very popular even in the Western countries. It was only during the H1N1 flu in 2009 that ECMO became very popular in worldwide. But still India lagged behind, and only after this COVID-19 pandemic that it is more familiar amongst the clinicians. People know about it, and there is a general acceptance about ECMO in India. The basic functions of our hearts and the lungs is to maintain tissue perfusion. So if there is any problem, any dysfunction in the right heart, left heart, or the gaseous exchange is impaired in the lungs, then the tissue hypoxia occurs. So this is here that ECMO steps in. What we do in ECMO is we take out deoxygenated blood from a large vein and pass it through a centrifugal pump, which the blood is passed to the membrane oxygenator where the gaseous exchange is taking place, and this oxygenated blood is given back to the patient either into the large artery or a vein. So what is ECMO? It is nothing but it's the use of extracorporeal circulation and gaseous exchange. So both circulation and gaseous exchange are important, and where we are using it, it's used in as a temporary life support in patients where they are having a reversible either circulatory or a pulmonary problem. So the primary goal of ECMO is to ensure that the tissues have enough oxygen. ECMO per se will not heal the lungs or the heart, but once you put the patient on ECMO, the lungs or the heart, which is not being able to perform its function, it can be put on rest, and later on, when the function of these organs recover, we can wean off the ECMO. So ECMO is a bridging therapy, it's a temporary therapy, and it is not a curative therapy. It is used either as a bridge to recovery, which is commonest in our country, as it buys time for the patient to recover, or a bridge to decision or a bridge to transplant. Suppose you have in an emergency, you have put the patient on ECMO, and then you assess how the patient is improving and which direction the patient is going. That is a bridge to decision. Or either you're sure that this patient is not going to recover with this only on this, and then you decide to put the patient on VAD or a transplant as a durable support. There are various stages of ECMO starting from decision to cannulation, initiation, maintenance, weaning, and even post-ECMO support. All these are important for a proper outcome of the patients. Indications of ECMO can be grouped as for either cardiac support or a respiratory support. So, selection criteria for the mode of ECMO will also depend on what is the indication. So there is a veno-arterial ECMO where we drain blood from the venous system and give the oxygenated blood back to the arterial system, and it will support both the heart and the lungs. That is, to support both the circulation as well as, because we are giving the oxygenated blood, is also supporting the lungs. And the veno-venous system where both the drainage and the return cannula are in the venous system, and it will only support the lungs and it will not support the circulation. There are other variants of ECMO such as VV, VAV, VVV. These are all different indications. The most important thing is to assess whether the organ that you are going to support, whether there is a likelihood of recovery or not. If it is not likely to recover, you need to see whether you have other bailout strategies or not, like VAD or a transplant. But in the Indian context, we always try to see whether the lungs or the heart will recover. The other relative contraindications being a patient having a multi-organ dysfunction or a disseminated malignancy where the life expectancy is less than 6 months. The patient is having a very advanced stage, or a severe brain injury where in spite of your ECMO, the patient is not going to wake up with a good heart or lungs. And if the patient had an unwitnessed cardiac arrest or a prolonged duration of cardiac arrest, all these are contraindications that you have to keep in mind before you go for ECMO. So the indications of ECMO has to be acute in onset, it should be life-threatening, it should be reversible, and unresponsive to the conventional modes of treatment. Indications of VV ECMO, that is a respiratory ECMO for respiratory failure, where you have utilized the conventional therapies and it is still not manageable. The commonest indication being ARDS, which can be due with pneumonia, bacterial or viral pneumonia. It can be with aspiration syndromes or alveolar proteinosis. ECMO is also used where you have difficult or impossible to maintain airway or ventilation, such as if the patient has a thoracic surgery, awake induction of anesthesia where the very severe compromised airway anatomy, resection of an airway mass, near complete airway obstruction due to foreign bodies, airway compression, or a disruption of the airway because of trauma. It will also provide lung rest in large bronchopleural fistulas, pulmonary contusion, smoke or chemical inhalation injuries, or drowning. Even in transplant patients who are having primary graft failure, or in the patients who will need a ECMO support as a bridge till we get a proper lungs for the transplant, there you can utilize ECMO. Other indications being severe bronchospasm or pulmonary hemorrhage or massive hemoptysis, which is flooding the lungs and you are not being able to ventilate the patient, or the poisoning patients. In neonates and pediatric population, meconium aspiration syndrome is the commonest, very common indication. The other indications is congenital diaphragmatic hernia, PPHN, hyaline membrane disease, ARDS. ECMO is also used in various tropical diseases, and it has been extensively used during the COVID-19 pneumonia. So, before you go for ECMO support, you need to assess whether this patient needs ECMO or not. So, how do we assess the severity of the lung injury? One of the scores that is very commonly used is the Murray score, which takes into consideration 4 parameters, and the numbers are given from 0 to 4, and the average of all these 4 scores will be your Murray score, final Murray score. What are the parameters that we see? There is a PF ratio, chest X-ray, how many quadrants are involved or not, how much is the PEEP needed to maintain the oxygenation, and compliance. So as the lung injury increases, you can see that the PF ratio goes on decreasing, the number of quadrants involved increases, PEEP needed is higher, and the compliance goes down. So as the average Murray score is more than 3, then your patient qualifies for ECMO initiation. Another very easy criteria to initiate ECMO is the EOLIA criteria that was used in the EOLIA trial. It takes into consideration only two things. One is the hypoxia and hypercapnia of the patient. So if the patient is severely hypoxic means if the PF ratio is less than 50 for more than 3 years, or if the PF ratio is less than 80 for more than 6 hours, in spite of all your rescue maneuvers, you have done all the ventilation strategies, you have done put the patient on proning, etc. In spite of that, if your oxygenation is not improving, go for ECMO. And another is if the patient's PCO2 is very high, more than 60, with a blood pH of less than 7.25, in spite of your increasing the respiratory rate, tidal volume, keeping the PEEP flat less than 32, there you have an indication to go for ECMO. ELSO guidelines also use this hypoxia and hypercapnia criteria, which is almost the same as that in the EOLIA criteria. So in treatment of ARDS, there are various modalities depending upon whether the patient is in mild, moderate, or severe ARDS. In patients with severe ARDS, if the patient's PF ratio is less than 150, you need to go for prone positioning. That we have seen in the ProServer trial that many of these patients improve. Even in the COVID situation, we have seen the many patients improving with the proning. And in spite of that, if the patient's PF ratio is going down, you have to go for ECMO. So what are the indications for the VA ECMO, the circulatory support? So that is mainly in the patients who are having a cardiogenic shock. So here you are using ECMO as a short-term mechanical circulatory support device. What is the objective? Is to provide adequate coronary, cerebral, and systemic circulation with effective left ventricular decompression. So these patients who is in severe circulatory shock, you need to decompress the failing LV, as well as you have to provide circulation to the coronaries, to the brain, as well as to the other vital organs, so that the patient stays alive. The commonest cause of cardiogenic shock is MI. The other causes can be myocarditis, post-cardiotomy as a bridge to transplant patients. It can also be used in post-heart transplant or LVAD, as in hypothermic shock, in arrhythmic storms where the patients are having a severe arrhythmias, you are not getting adequate ejections. Backup in high-risk cardiac interventions is common in the utility in cath labs. Postpartum acute cardiomyopathy, which is quite common. Drug intoxication, sepsis, trauma, massive pulmonary embolism, even in endocrine emergencies, and last but very importantly in cardiac arrest, where in spite of your adequate CPR, the patient is not having an ROSC within a stipulated time, and if you have the ECMO support available, you initiate ECMO, have the circulation going, and then the cardiac function will recover with time. So suppose you have a patient of MI, they will have various mechanisms by which they will can go down and lead to death of these patients. So at what time in this clinical continuum do we need to intervene? Because all patients will not go to this stage. So we need to understand at what point this ECMO support or the support of circulation is needed to prevent death of the patients. So cardiogenic shock starts as a hemodynamic problem, but if it is not treated properly and in time, it changes to a hemometabolic problem where you have multi-organ dysfunctions. And this change over to a hemometabolic problem, even if you initiate mechanical circulatory support at this stage, it's of no use because most of these patients will eventually die. So timing of ECMO initiation in cardiogenic shock is very important. The clinical scenario, most of these patients will be having hypotension, low urine output, higher lactate, mixed venous saturations are low. Patients will be having altered consciousness and they will be unresponsive to the optimal management. You have given fluids or diuretics, inotropes, inodilators, vasopressors, you have ventilated the patient. In spite of that, the patient is going downhill. And most importantly, you have to ascertain that the patient is having a potentially reversible cause of this cardiogenic shock or if it is a surgically correctable cause. So ELSO guidelines state that the VA ECMO has to be considered in cardiogenic shock within the first 6 hours of its occurrence. If the patients are having refractory cardiogenic shock, that is refractory to the conventional pharmacological and fluid therapies, and the patients are having the cause of this shock is reversible, or if the patient is having an alternative cardiocirculatory assistance, such as if the patient is having an irreversible process, that is the heart will not improve, that is acutely failing heart, but it will not improve, then you have to go for VAD or a transplant, whether the patient is eligible for that or not. If it is the patient is not eligible, then you do not go for ECMO. If you classify the heart failure stages by Intermax, that is the Intermax class 1 and class 2, they are NYHA class 4 stages of heart failure. The class 1 is the crash and burn, and the class 2 is the sliding on inotropes. This is there that you have the indication for ECMO support. You need to stabilize these patients on ECMO. They'll either recover, or if you see that they are not recovering, you have to think about VAD or a transplant. In these stages, do not go for directly or a VAD. They will not do very well. Even the ESC guidelines of 2021 have stated that the ECMO utility is a class 2A indication with a level of evidence of C. What are the contraindications of VA ECMO? In patients where the cardiac recovery is unlikely, and there is no indication for transplant or a durable left ventricular assist device. In patients who have severe irreversible non-cardiac organ damage, which itself will limit the survival of the patient. Patient with aortic regurgitation, severe vascular diseases, or type A or type B aortic dissections, in severe neurological impairment, where in spite of ECMO, if your heart improves, but the patient will not be able to lead a normal life from the central nervous system point of view, and in patients who are having cirrhosis or a severe immunological diseases, there it is contraindicated. So VA ECMO is used as a mechanical circulatory support device. There are various other mechanical circulatory support devices, but why VA ECMO has to be preferred and in which situations? VA ECMO gives a biventricular support. This is the most important thing because none of the other devices give a biventricular support. Patients with malignant arrhythmias can maintain adequate circulation with VA ECMO. Since ECMO is incorporating a gaseous exchange, here, even if the lungs are not functioning properly, you can put the patient on VA ECMO. So it also gives a pulmonary support which other mechanical circulatory devices will not provide. And it is very quick and easy to implement in experienced hand. And comparatively, the cost is also quite low compared to the Impella or the other mechanical circulatory support devices that we are currently using. Finally, the take-home message is that you have to assess and choose your candidate for ECMO very wisely and early. But first, you need to give them the adequate time with conventional methods of management. Once you have exhausted that, you put the patient on ECMO. Choose the modalities of ECMO depending upon the which organ you need to support and ensure that the tissues get adequate perfusion. So ECMO isn't a tool to delay the inevitable, but to give a chance to recover. This is my very favorite slide and I'll conclude with it. So if you ask me what is my job profile, it is like a Zomato delivery guy who is delivering food to your home. You and I help to deliver oxygen to the tissues because oxygen is essential for survival. Thank you.